Alright, so this is going to be a little bit of a longer video. We're going to cover safe FiO2 and PEEP titration, decision making regarding intubation of COVID patients, and the nuances of intubating a patient with COVID-19. So here's the pathway that I've drafted up for managing these patients. We're going to walk through this step by step. So the first question when you see somebody who you think might have COVID-19 is, do you have time? This is largely going to be determined by what phenotype they present with, either the L or the H. So if you determine you do have time and your patient is an L patient, the goal is titrating up their FiO2. So the first thing you're going to try is nasal prongs up to 6 liters. That's going to provide about 40% FiO2. If that doesn't work, you're going to move on to the HiOx mask. So essentially the HiOx mask is a closed system that is designed to provide relatively high FiO2 given the originating source of O2, and the additional theoretical benefit is that all exhalations are filtered. The major benefit of the HiOx compared to other options is that only one source of oxygen is needed and you don't need too much flow out of it. So here's a study that was done to compare the HiOx mask to other options. I've converted things to rest rate, assuming tidal volumes of about 500 cc's. Running 4 liters to the HiOx mask gives you about 45 to 60% FiO2, and running 8 liters to the HiOx mask gives you about 65 to 90% FiO2 based upon how fast they're breathing. The HiOx isn't rated at flows higher than 8, so I wouldn't recommend going above that. If you get your patient on the HiOx and they're still not satting great, the other option to consider is the classic combination of nasal prongs and the non-rebreather at flush rates. This is going to require 2 sources of oxygen, which makes logistics a bit more difficult, and we don't have good data on how aerosolizing this is. Alright, so you've titrated your patient up to 100% FiO2 and they still are not oxygenating great. One of the other things to try that people have sometimes found works very well is proning. So essentially the way proning works is takes the weight of the abdomen off the lower portions of the lungs, and it also equalizes the mechanics within the lung. So essentially alveoli that are hyperdistended end up being less distended, and alveoli that are collapsed are more likely to open. This also decreases the shunt physiology that is associated with COVID. The important thing to know about proning and positional changes is that this is a transient improvement in their SATs. So this is really buying you time. Okay, so if you got your patient up, you've proned them, nothing's working, they're probably closer to the H phenotype, which means they need PEEP. So there are a couple different options you have to provide PEEP. I think the ideal situation, what people are finding, is that the hood CPAPs are a really good option. This only requires one source of FiO2 and provides low flow PEEP that we think is minimally aerosolizing. This is what we see used in Italy and increasingly in New York as well. Another option is regular CPAP or BiPAP. Now at first this wasn't recommended because of the rate of aerosolization, but we're starting to see it used now in the larger centers. The problem with this use for us in a smaller center is that we need to transfer them, and it really depends on what EMS and what the receiving center is okay receiving. And of course we've got the Weingart mask, which is an alternative to providing relatively safe CPAP. Keep in mind that with all of these positive pressure options, you need to manage your patient's anxiety. Alright, so let's say you've given them PEEP. For one reason or another, this patient requires intubation. So the goals of care discussion around COVID is extremely important. Most of these guys that end up on any sort of positive pressure require hospitalization with this positive pressure for about 10 to 14 days. Early studies are also showing 67% mortality in intubated patients in the ICU, 2 to 6% peri-intubation arrest, and perhaps the worst part of this disease, people who are dying in ICUs often have one or no families present when they die. The physiologic reason we think we need to avoid intubation is because once these patients are intubated, we have a really difficult time managing their tachypnea. Even with large doses of opioids and benzodiazepines, the rest rate stays high, and so there's a large amount of ventilator dyssynchrony that happens that causes further lung damage. Alright, on to the indications for intubation. Remember that with these happy hypoxics, your SAT isn't really going to work. This is a real patient. They're breathing, the pleth is good, their SAT is 1%. You can't rely on the SAT. What the people in New York are thinking are reasonable reasons to intubate, and keep in mind this is all anecdote. Increased work of breathing, specifically not only increased rest rate. So COVID is a disease that causes pleuritis. So patients are purposely taking shallow, rapid breaths. Simply increased rest rate alone is not a good reason to intubate these patients. Increased work of breathing with accessory muscle use and all those other things are. You expect these patients to have a decreased PCO2 because they're breathing so quickly. If it's elevating, you're probably headed in the wrong direction. And finally, of course, mental status. So other nuances of COVID intubation. These patients are not starting at 100%. If they've gotten to this point, they're probably satting closer to the 80s or 90s. You have no time to intubate these guys. When you paralyze them, they will rapidly desat. It's important for both you and your team to know this, because not only will you have very little time to intubate them, but your team needs to expect that desaturation to keep their cool. Keep in mind that below 80%, O2 sat monitors really don't work very well at all. To pre-oxygenate these patients with the Weingart mask, you should turn up the distal O2 source up to 10 liters from 6. George Kovacs has done some work in his cadaver lab and figured out that you really need 10 to adequately pre-ox. You've got to optimize these guys' physiology. The important thing here is doing what you are used to, because that will allow you to get the fastest tube, but we know that position changes the amount of safe apnea time that we have. Also think about using pressors in these guys, not only push dose, but also starting a drip before you go for the intubation attempt. Alright, once you've made sure you've got everything at the bedside that you need and you're ready to go, you push the drugs. Remember that both succinylcholine and rocuronium have longer onsets than you probably think. You should wait about 60 seconds before you put anything in the patient's mouth to avoid getting coughed on. Some VL monitors will have timers on them, so you can look at that to help you. Now, once you push your drugs, keep in mind that once your patient becomes apneic, you need to keep the airway open with an aggressive jaw thrust to continue the oxygenation. On these lines, your assistant may need to switch the CPAP mask to a regular cuff seal mask to allow you to do this. It'll also be key for re-oxygenating your patient if you need to make more than one attempted intubation. Keep in mind your backups and have them at your bedside. Now, on the note of saturation dropping, it's really important that we all appreciate pulse ox lag. So take a look at this video. This gentleman has held his breath for a number of minutes and his sat is currently 83%. Take a look at the lag between the time where he starts breathing and the O2 sat catching up. It takes about 25 seconds for that O2 sat to go up from 83 to 90 in a perfectly healthy patient. What you want to avoid in a high stress situation is looking at that O2 sat or absence of an O2 sat and aggressively bagging. That's not going to oxygenate the lungs. It's only going to insufflate the stomach, which is not going to help you at all. With the Weingart mask, if you are going to squeeze the bag, you only need to squeeze it twice to completely get their lungs to re-expand. You don't need to bag aggressively at all. In a high stress setting, seconds feel like minutes, and we often abandon something that's working because of this pulse ox lag. Just keep in mind that it will take time for your patient's sat to come back up. All right, once you secure the tube, remember balloon, filter, bag. They found in New York that oftentimes when these patients are intubated, their stats will drop and stay low for about an hour or so. That should be expected. Your target O2 sat after you intubate them with the vent should be at least what their pre-induction sat was, if not higher. All right, that was a lot. Let's recap. The first question you need to ask yourself is, do you have time? Which presentation is this? That's going to inform where you start with your O2 titration, and don't forget to prone these guys to buy yourself time. The name of the game is PEEP, and the choice of which is a logistical decision. Try not to intubate if you can. If you need to move to intubate, remember to have an early discussion about goals of care with your patients. Remember the O2 sat is not reliable. And remember your indications to intubate. Respirate alone is not a good indication. Remember you have very little time to intubate. Do what you know and do what works for you. Do not get overly excited if you don't get the first attempt. It is likely that your O2 sat will be very low or will be absent. Do not hyperventilate these patients. Have your backups ready to go, and don't forget to protect yourself by putting a filter on. And that's it. That is the management of a COVID-19 airway. Now that you know what to expect, your primary job is to keep your nerves with you when you're hot and dressed in PPE and everybody else around you is stressed. Thanks for listening.